Excellent. So the guys asked me today just to talk through
Morningstar. Thinks this is clear.
A little bit of our process around moving from hard collars through to soft collars. Our centre, for those of you that don't know anything about Canberra, because I think some of it is relevant to context to how you look at rolling out these things over a period of time. So we're a big...
There's code blue. Any response?
We are the referral centre, about 18 other hospitals, being one hospital in the ECI and about 17 hospitals in regional New South Wales. And one of our unique challenges is that we have to deal with 2 states, 2 health departments, 2 ambulance services, and 2 retrieval services, and 2 levels of government and media. I did just want to go back a little bit and describe where we were at in 2011 and say that soft collars have been part of a process. So in 2011, like many EDs, we were grossly overcrowded with a very small emergency department with very long waits in corridors. I know ramping is topical, but the ACT has no ramping. So ambulances from both New South Wales and the ACT always offload into our ED and always offload into corridors if there are no beds. So we would commonly have 12 to 15 patients, sometimes in our corridor, of which we could easily have 4 or 5 patients sitting in a hard collar. This was exaggerated by us having no on-site CT radiographer or radiology reg overnight and no teleradiology service, so patients waiting in collars for long times for definitive imaging. So deliberately as a process, we had a series of steps for improvement. So we have 2 nurse practitioners working here. So starting in 2012, we had a process of training our nurse practitioners to be able to assess patients under Canadian C-spine rules and clear them out of collars prior to imaging or medical assessment. We then went to extended scope physios. So we have a high-end physio working in our department 16 hours a day, sort of almost 7 days a week now. So we taught our physios how to assess patients in collars and to remove the collars. We got an agreement with radiology that being in a neck collar would always be a reason for an overnight CT, which seems logical, but took about a year of work with those guys. And in 14-15, we opened some beds. We had some big changes to flow, so patients stayed in collars for a lot less. And then we got on-site radiology, both registrars and CT radiographers from start of 2015. So our rate and time of people in collars sort of dropped to about 40% of where it had been. But then things kind of stopped. So by the end of 2016, we were still using hard collars in the ED, still using hard collars from both of our ambulance services, and a policy that had hard collars as a mandatory requirement for transport to CT. Just want to remind people of, that data for why we think about it. This is not a talk about the science. There's a lovely summary already on your ECI website, but just to remind people that the reason we talk about collars is that essentially all collars are hopeless. So this is a paper looking at the amount of movement that you have based on no immobilisation soft collars or our traditional hard collars. So you can see that there's huge amounts of movement regardless of what we choose to use. Number on the right that's a little bit blocked by the Skype window is tape plus sandbags plus a Philadelphia collar plus or minus nurse intervention. So really that's the level of interface you need to try to decrease movement if you think that's important. We'll talk about soft collars a little bit in a moment, but the point isn't that soft collars immobilise necks. The point is that hard collars don't immobilise necks either and probably cause more harm. So what then happened? Well, in January 2017, there was a lot of discussion going on. There'd been a discussion group for about 3 months who looked at the data from around the world and in particular from Queensland. And there was a large push that was initiated by ACT Ambulance to change to soft collars as per the Queensland process and protocol. In classic big hospital fashion, there were a bunch of meetings with a large group of people and there was definitely a plan for a plan, but there wasn't really a plan. And progress had been pretty slow. And then ACT Ambulance kind of shook things up and just unilaterally decided that they were going to change. And interestingly, the trigger for that was stores. So they had stopped ordering in hard collars and had started ordering in soft collars and realised essentially on a single week of January that they were about to be out of hard collars. So they just decided they were going to go to soft collars. And the first we knew about a definite date was late on a Friday afternoon when a bunch of patients from a 5-patient motor vehicle accident all appeared in a soft collar, creating a little bit of consternation in the hospital at that point in time. The process got a bit messy. So we had no soft collars, so we couldn't put our patients into soft collars. Our protocols had been discussed but not signed off. They weren't anywhere with anyone. So in fact, for 3 days, we had a crazy system where patients were coming in soft collars and then going back into a hard collar in the emergency department, and until their neck was either cleared or they were admitted. But we managed by the Monday of the next week to actually get in an interim process with radiology, with our wards and with our staff about use of soft collars. Where are we at now? Well, we have a generalised agreement and we have a formal policy that in classic big hospital fashion is still sitting in the policy committee, so 10 months later is still not formally signed off, but soft collars have become routine practice pre-hospitally, and still in the emergency department we're using soft collars. But there are still some issues. So the neurosurgical ward has had a long-term policy for collars, which doesn't include soft collars, but they very rarely, I guess, get an undifferentiated neck. So by the time they get the patient, they either don't have a fracture or they do have a fracture, and it's rare they get the undifferentiated neck where that becomes an issue. Radiology are very didactic. So patients going for imaging are required to have a soft collar, imaging of their neck are required to have a soft collar on, and that's essentially a blanket rule. The radiographers have been told by their chief that they are liable to be sued if they do an image on a patient without a soft collar on. So if a patient, for example, has had ongoing neck pain for 9 days post-accident and it's felt that imaging is needed, we end up putting them back into a soft collar, which is fairly ridiculous. Ambulance had hoped to move to pre-hospital assessment using the Canadian C-spine rules because of their greater clinical utility and their bit more nuanced behaviour, but in fact, pre-hospitally, they're probably a bit too complicated. So they've gone back to Nexus criteria. But we still have patients transported with soft collars that we choose not to image, and that we are teaching our residents and our senior nursing staff about Canadian C-spine rules, so some of those patients will get cleared. But I guess importantly, in 10 months, we've had no complaints, we've had no documented issues, we've had no referrals to our M&M committees or the hospital's legal committee around our use of soft collars. So what do we do if there's a fracture? Well, much like Queensland, one of the areas in Queensland that there's ongoing debate is what do you do if there's a fracture? Because my understanding is that the EA spinal unit actually manages all of their patients, whether they're positive for fracture or not, with a soft collar. But other areas in Queensland don't do that. And although our policy says to stay in the soft collar, it's not yet, that part is not yet fully signed off by neurosurgery. So once the imaging's done, if they have a fracture, they're still going into either a Miami J collar or a Philadelphia collar. Now that has created some issues because it's created a greater focus on who's trained to fit one of these collars. So we have physios who are trained to fit it, but they don't believe they're trained to teach it. We have trauma coordinators who are trained to fit it, but don't believe they're trained to teach it. And we have a trauma nurse practitioner who does all of our teaching, but we are commonly in a position where there's no one in the ED who's trained, in inverted commas, to fit a Miami J or a Philadelphia collar, which creates a little bit of consternation with our neurosurgical registrars who are sometimes asked to come in simply to fit those collars. Stakeholders for collars are bigger than you will think. So for us, it was 2 ambulance services and then staff in multiple departments. So emergency, trauma, radiology, anaesthetics, intensive care.
Cat 2 to acute 19.
Sorry about that. Neurosurge, then our networked hospitals, and in particular stores, because we ran out over and over and over again of soft collars in the early days because they weren't told how much more of these we were going to need. There has been another ongoing issue with ambulance, and that because our ACT-based ambulance interacts continually with New South Wales ACT helicopter service interacts with New South Wales ambulance service, they've chosen not to create a potential for conflict or difficulty, so they are using hard collars pre-hospitally and have been working with our region to change that. That hasn't gone anywhere so far. And they are, in fact, going to unilaterally change, which will be an interesting trigger to our New South Wales ambulance colleagues because They will be delivering patients to the helicopter with a hard collar, and that collar will be changed to a soft collar prior to the patient being transported. This won't be news to many of you, but just to note that the soft collar is essentially a flag that the neck is not cleared. That's all it's there to do. It provides little support, possibly some placebo value or psychological wellbeing value to the patient and the staff, but it's a practice enabler. It's to make us think, this patient we need to be careful with, their neck is not cleared, and what is the process that we're going to use to clear the neck? But it's been good in that it's enabled us to better integrate teaching about immobilisation, about clearance protocols, and about other techniques to immobilise the patient. So for us, we've seen that very much as a positive. Again, I can't stress enough the issue about stock, because we've literally run out 6 or 7 times, and it's very difficult to try to be consistent with a policy. Go back to your hard collars because you don't have the soft collars in the ED. And I guess my final point really is that, remember, it's the full spectrum. So it's not just the collar. It's about your teaching, your assessment and the integration. So working with the ambulance service, working with your triage staff, working with your junior doctors. So we feel like we've almost got rid of patients being sent for cervical spine imaging having not been examined. And we are insisting that they are documenting under what process they are imaging the neck, under what process they are clearing the neck. We have got rid of plain films entirely for C-spines, so we don't do them. We either clear the neck clinically or go straight for CT. And then you have to integrate it into your discharge advice and into your admission processes. So my advice for those of you thinking about doing it is just do it. In the end, for us, I suspect it would have taken another 6 months if ambulance hadn't just started it. And sometimes just starting it is the trigger that you need to get it to happen. But I don't think anyone here would consider going back. We don't feel we're placing patients at any risk. And for us, it's been essentially a highly positive experience altogether. So I'm really happy to answer any questions that you might have.